George Kilpatrick, Inspiration for the Nation, celebrating people we feel good about. And there's a subject that we want to talk to you about today, and it's suicide prevention. Teen suicide rates among Black youth are increasing according to recent studies. In 2016 and again in 2018, national data revealed that among children aged 5 to 11, Black children had the highest rate of death by suicide. And for the years 2008 to 2012, 59 Black youth died by suicide, up from 54 in the years 2003 to 2007. Also in 2015, the Centers for Disease Control and Prevention's biennial youth risk behavior survey reported that compared to non-Hispanic white boys, Black high school age boys were more likely to have made more serious suicide attempts that require medical attention. This is an important issue that we want to talk about, and we're pleased to be joined by Dr. Wanda Averhart. She is a pediatrician based in the Syracuse area, and we're so glad that she's here to help us understand, number one, why this issue is something that we need to talk about as a community, and more importantly, how your healthcare medical professional, specifically your pediatrician, can help. Dr. Averhart, welcome to the program.
Well, thank you, Mr. Kilpatrick. That was an excellent overview of the issue that we like to address today. And yes, I'm Dr. Wanda Averhart. I am a general pediatrician here in the Syracuse area. I am currently with Brighton Hill Pediatrics, and these are the topics and issues that we talk about every day. So it's very important to address this with your doctor. It's important to talk about how this impacts our youth, especially our youth of color. So I'm glad to be with you this morning. Thank you. And if you hear anything as far as piano lessons or music, that's my daughter. You know, we're all in this Zoom world where
Listen,
everything's occurring at the same time in one house.
listen, and you know, and later on, you'll probably be doing a lesson, and then you'll be the
You're
teacher, the tutor.
actually telling my whole Saturday.
Right. That's Zoom life, and God bless parents. I am beyond that stage, thankfully. I don't know how y'all do it, but thankfully all of my children are adult age, and so they are in school, but they're on their own. They're in college, so I don't have to worry about them doing their homework. But let's talk about this issue of suicide prevention, and specifically, what are some of the issues, especially now that we are also within the pandemic, and whether or not we're seeing some of these issues exacerbate or see these issues exacerbated due to the pandemic. So, Dr. Averhart, I'd love for you to just take us through some of this.
Yeah. So, I mean, you gave some really, really nice statistics in the beginning about where we are with this issue. And so, first of all, based on the American Academy of Pediatrics, suicide in general is the third leading cause of death in adolescents ages 15 to 24. This is only third to unintentional accidents like motor vehicle collisions and homicide.
Mm.
In general, this issue with suicide has been increasing. And so the statistics before the pandemic, between 1991 all the way till 2017, suicide attempts in Black adolescents increased by 73%. And that's a lot. I mean, in that one study, it was about almost 200,000 high school youths that they surveyed, and they got that number. So that shows us that this is an increasing issue within the African American community. And now, since the pandemic, there's been very little research, but I was able to find a study that they did in the one of the Texas pediatric ERs, where they found that adolescents in general are 1.6 and 1.5 times higher to say they've had a recent suicidal ideation, meaning a thought of wanting to commit suicide in March and July of 2020. So this is during the beginning of the pandemic versus March and July of 2019. So that tells you that kids now, at least in this pandemic, are thinking about suicide at a lot higher rates than they were before the pandemic. And even before the pandemic, African American youths were attempting suicide a lot higher. So this is a big, big issue.
You know, Dr. Averhart, when I think about that, this is where we have to kind of take a look at what's going on, because our perception of suicide it's not an issue for us, right? That the perception is this is not something that we have to deal with. It's very rare in our perception that this is something that is even a problem, and yet the statistics show that unfortunately things are increasing in our community. Now, here's my, and I'm thinking about it in this way, right? There's obviously in some areas of our community, trauma related to homicide rates and other poverty and these all of these kinds of issues. And yet we didn't see this sort of thing happening. What is the difference now, do you think, of why we're seeing these rates of increase, particularly among Black boys?
So I can't tell you the exact reason, but I can tell you what I suspect.
Okay.
Over the time, it has definitely not been given the light in African American populations. As a lot of us know, it's definitely a stigma
Mm.
associated with discussing mental health in the Black community, and even a stigma associated with talking about suicide in general. So I think that is one of the reasons why in the past we weren't able to shine a lot of light on it, or we didn't know a lot about what was happening. And now people kind of feel more comfortable to talk about it, to delve into it. And then one thing I think that also brings these numbers to light and kind of elucidates where we are is that, at least in the pediatric community, when we have adolescents that come in for their usual checkups, we do what's called a universal screening. And so we do a universal screening for suicide and depression, meaning all kids that come in, we ask them if they've been sad, if
Hmm.
they've thought about suicide, and then we go into whatever else we need to talk about once those questions are answered. So even just having the ability of every teenager, if you're in your doctor's office, to just answer that one question, that can help shine some light on the issue.
And so you said there's a depression screening. So you
Yeah.
asked that question directly. So at what point, this is about 11 years old or so when you're asking these questions? Is
So
that,
if
it's a little late, right?
Well, it varies based on the clinic. Some clinics will start at 11 and ask you about depression, sadness. What we call it is the PHQ-9. So it's
Mm-hmm.
or PHQ-2. So it's a set of questions. Initially, it's two questions that we ask you about sadness and so forth. And then if you answer yes to any of those questions, then we ask you more. And within that PHQ-9, we ask the suicide question. And so those are our main strategies, but each clinic is different. A previous clinic I used to work at started at 11. The
Mm-hmm.
clinic I work at now starts at about 15 with
Mm-hmm.
asking those questions.
Mm-hmm.
And the other thing is, whenever you come in for a regular checkup, we always ask you how you're feeling. And
Mm-hmm.
so if there's anything that comes up as a red flag, as in you've been very sad, you don't seem very interested in what you used to be interested in, then those are things that we can kind of try to get a little bit more information from you and see if that's something that you're thinking about.
If you're just joining us, we're talking with Dr. Wanda Averhart. She is a pediatrician in the Syracuse area, Brighton Hill Pediatrics, and we're talking about suicide prevention, and in particular, with a particular focus, of course, with our audience on the African American community, and why, for example, the rates of suicide is increasing, particularly among Black youth and Black boys in particular, and perhaps some of the reasons why. And one of the things you alluded to is the fact that mental health in general is something that we're getting better at, but we're still not
Definitely.
there yet in terms of having open conversations. And that, as a pediatrician, as a gatekeeper, right, you have a particular role in helping us to identify some of those signs and symptoms. And so how should we use our pediatrician in this process? Because on the my again my from my awareness of it, it's not something that I would normally think, oh, my pediatrician is going to help me understand what this particular issue. You did say that you have, of course, the PHQ screening. Did I get that right? Did I get those letters right?
Yes, you did. You definitely did.
You talked about the PHQ screening, but you are an important gatekeeper. So let's talk about two things. One, if you have a pediatrician, right? Because some of us have family versus pediatrician. So is that the same? Or is it different? And so how does a pediatrician help us to identify these signs and symptoms, starting with the PHQ score? What are the other things that you might see?
So, I mean, what we have to think about, so answer the first question,
Yes.
whether you have a pediatrician or a family medicine doctor or a general practitioner or a nurse practitioner, everyone is trained in the current screening guidelines. So everyone knows how to screen for these things. And then everyone knows how to get the appropriate care if you were to be suicidal or if you were to show signs of suicide. So I wouldn't care which doctor or which
Right.
provider you saw, everybody
Right.
can treat you.
Right.
And then I kind of want to talk about the fact that suicide is an endpoint a lot of times for a traumatic life, a depressed life, for some type of psychological issue that isn't being treated. And
Mm.
so a lot of times what you have to do is kind of get the child or get the adolescents at that point before they start committing, thinking, or acting on those suicidal thoughts. And sometimes that can be as simple as identifying a child that's depressed. And so I think your question was asking if there's ways to identify it early or ways to find out if the child is suicidal. And that would be trying to understand their psychological health beforehand. And so that would be if a child is acting erratically, making sure you get them into counseling, trying to figure out if you can get them a diagnosis, if they happen to be bipolar or schizophrenic, so that all of those things are treated so that they don't end up thinking or trying to commit suicide.
You know, the thing that occurs to me is that a lot of the screening would be done with the parent present, I assume, or am I wrong about that?
No,
No, okay.
no.
Okay, good. All right, thank you. Because what I'm also thinking is that perhaps some of the other issues is if there's abuse in the family or if there's some childhood trauma related to sexual or domestic abuse, and there's no way, to be able to develop that trust. Usually a child is not going to tell anybody. And so
Yeah.
how to get the children comfortable and trusting any adult when it's likely that it's an adult that caused them harm, and that
Mhm.
trust and that boundaries have been broken, which leads to thoughts of suicide because you don't have any place else to turn. Did I just make a point, or am I off the chart, am I off on that thought?
No, you've made an excellent point. So, yes, children that have had some type of physical or trauma or abuse, it can be hard for them to connect with another adult after something like that. As a pediatrician, of course, we've been trained in how to interact with children
Hmm.
that have had such traumas. But then when we do the screening, we also try to make it as private as possible.
Hmm.
And so, universally, what we've been trained to do is that when children become of an age where they can show their independence. So we think that they seem a little bit more independent, and that's usually around 11, 12, 13. We'll ask the parents for a moment alone to talk to the child, as simple as, hi, I know you guys are here for your well child checkups, but universally, when children reach this age, I tend to just give them a few minutes just to talk to me by themselves, just so they can start to feel comfortable talking to their doctor alone.
Hmm.
And then you get the parent out. And I usually will ask the child, are you feeling safe at home? Is there anything that you have questions about? Are you questioning your body, your development? And the child will respond. Sometimes it doesn't go off well, but that's your effort at trying to build a rapport. And as a pediatrician or even any type of general practitioner, the advantage we have is that we see these children multiple times, or at least you
Hmm.
hope you see the children multiple times, and you can develop a rapport. And so as soon as you establish that with the parent, children are given a moment alone with the doctor, that allows them the ability to do that and disclose those information if they have them. The other thing is when we do the screening, we try our best to make it as private as possible. So we give the screener or the sheets directly to the child covered, right? And we tell the parent, hey, this is for your child fills it out, they keep it covered, and the provider is the only person that sees that sheet once it's completed. So that's our effort.
A lot of times families obviously are taken, they're caught off guard, is what I'm trying to say. When this happens with a child, they miss some of the signs and they aren't prepared. No one is prepared for that, obviously. And so, what are some of the risk factors aside from the depression screening, if I've got a child, no matter what the age is, as we shared earlier, some of the suicide is very young children. So what are some of the risk factors? And then let's talk about some of the protective factors. And I think one of the other things that you wanted to talk about is that suicide attempts should also be included in this conversation, because there's the attempt and there's obviously the completion.
Exactly. So that goes perfectly into what the risk factors are. So the number one risk factor for any suicide attempt or completion is a history of a suicide attempt.
Hmm.
Period. Number one risk factor. Other risk factors include if you have a family history. So if you have a relative that passed away from suicide, children are more likely to attempt. If there's a history of child abuse, we talked about this. If there's a history of some type of mental disorder, of course, that can be depression, that can be substance abuse, and that can even just be feeling isolated.
Hmm.
If there's physical illness, uncontrolled physical illness, if there's barriers to mental health, or even a person that's just unwilling to talk about their mental health or talk about their substance use, these things all make you more likely to have suicidal thoughts. Now, the protective factors, they're pretty much the opposite of what we talked about. So if you have effective clinical care for your mental illness, for your substance use, for physical disorders, those are all positive things that make you less likely. If you have easy access to clinical interventions, easy access to medical care, that's excellent. If you have a supportive family or supportive community, that feeling of connectedness to the people around you, that's also protective. uh, those that have good problem solving skills, that can resolve conflicts, that have nonviolent ways of handling disputes, those are characteristics of people that are less likely to commit suicide. And then one of the important things I see is these cultural and religious beliefs. When
Ah, I
they
was,
discourage suicide, that is very protective against someone getting suicide.
but when you said family, it made me think of one other category of youth that we have not addressed, and that is youth who are not on the binary scale, right? That identify outside of the binary as gay, lesbian, transgender, queer, uh, bisexual, and that the fact that they don't find the support or the protective factor of a family also increases the likelihood that these young people might attempt suicide.
Yeah, and just think about it, that isolation,
Hmm.
that not having that community bond and not having easy access to everything, all those things kind of go hand in hand with what it's like to be someone that is LGBTQ or questioning.
Hmm. And so I wanted to name that because I think it's very important, because you mentioned religious, right? So religion as a protective factor, but also as a weapon. Let's be clear. Let's be frank about that, right?
Yeah.
That it also can be a barrier for young people to feel whole and loved, even at the same time as they're also protected. So
Mhm.
it can work both ways, and I think we have to name that and challenge our faith communities to really take a look at that. Are they welcoming or are they not? And I think that's the challenge for
Yes,
them. You're right.
that is excellent.
So the other piece that I wanted to also highlight is by gender identity specifically, that men are more likely to successfully complete and use more lethal means.
Yeah, I mean, if you just think about what women and men kind of think about in their lives, men are more likely to try suicide and actually succeed because they use more lethal means, such as a gun. And of course, that causes more damage.
Mhm.
Women are less likely to cause physical damage. They're more likely to attempt, but less likely to be successful. And that's because they'll use pills or medicines, things like that, to try to commit suicide. And so that's one thing to think about. And that goes into one of the questions we typically ask children and their families. Do you have a gun in the home?
Mhm.
And so kids that have access to a gun, that makes them more likely to also try or commit suicide. And so our recommendation is, if you have a gun in the home, the gun needs to be locked, and the bullets need to be in a separate place that is also locked. So they need to
Mhm.
be away from one another. So that's some guidance we always give parents.
What about substance abuse, overdosing as also factoring into this rate of suicide?
hmm So that is definitely a factor. With children, I'm not sure what the exact rate is of children and how many are trying suicide based on pills or things like that and overdoses. But it's also something that we talk to parents about quite often, especially when you have children that are young, because it's very common for children to end up in the emergency room with accidental intoxication or ingestion of a medication.
As I think about it, talking with Dr. Wanda Averhart, she's a pediatrician, Brighton Hill Pediatrics here in the Syracuse area. The thing that is striking to me, though, is that oftentimes as parents, we miss something that's right in front of us. Help us walk me through what we're missing, because, what some might say, so and so seemed like a very happy person. What did I miss that was going on, that next thing I know, this person who I birthed into this world has now taken their life?
Yeah.
What did I miss?
Yeah, so it's very shocking and very difficult when a family member commits suicide. And I think the loved ones usually think about, what did I miss? And I don't like to frame it that way because I don't
Hmm.
want to put guilt or on that blame, or that blame on that family member.
Hmm.
But there are signs, there are things that you can look for to see if your child is at risk. Kids that are contemplating suicide can sometimes outright just say, I'm better off dead. I
Mm.
wish I were dead.
Hmm.
Those are things that we need to take seriously.
Hmm.
I think in some families, your child may say, I just want to kill myself. And you just brush it off and you don't think it's something serious. But those are words that we need to truly take serious. Kids that are thinking about suicide can sometimes start giving away things that they really like, giving
Mm.
away their video games, giving away their jewelry. And this can be the only sign because they know they won't be here to enjoy it. Other signs can just be your child is very, very depressed. They're isolated. They're staying in their room. They're on YouTube more than they used to be. And I know kids kind of play on YouTube all the time, but they're showing subtle changes in their behavior. So overall, as a loved one, as a family member, what you have to do is just have a low suspicion.
Hmm.
That means if you see something different, always have it in the back of your mind so that you're thinking about it and you can pick up on these subtle clues.
And is it also? I've also heard. I've also heard that Dr. Averhart, that if you have if someone says, for example, that they are that if they make a threat, that you should take that threat seriously and ask some questions. If you hear a threat, what kinds of questions can you ask?
Yes. So if you hear someone say, "Oh, I want to kill myself." I mean, first of all, stop what you're doing and just ask them, do you really want to kill yourself? Is this something that you truly been thinking about? You would be very shocked. A lot of the children I've come across, they've been very open, and maybe it's because of my place of privilege of being a pediatrician. But I ask them, are you truly thinking about suicide? And they'll say, well, kind of, sort of. And then just go into detail. By asking a child about suicide, you're not implanting it in their head and you're not going to make them more likely to do it. So do not be fearful of asking them more questions. So I'll typically ask, so what's your plan? What do you want to do? Okay, why? And the more detail you have, you can start to think, well, wow, they really have a plan, or they don't have a plan at all. They just said this. Not to say that it's something you should brush off, but it gives you a good clue as to what's going on. But whenever you have a question or you want to dive deeper in those situations, it's not enough to just ask questions. I think you need to consult with a healthcare provider or mental health provider to get more help for that child.
I would never think of um, like, it's not intuitive actually to think about asking somebody if they're contemplating taking their life, right?
Mhm.
It's not something that you would normally think to ask. And actually, I would be afraid to ask that question. So, I mean, you just just ask, have you thought about it? I just wouldn't want to do that.
Yeah.
So, uh, you understand what I'm saying? So,
Yeah.
like, when you just ask them, well, do you have a plan? I would never ask that question. So you're telling me that I need to ask that question if
Well,
that actually
I
happens.
want to give you permission, okay?
Okay.
Permission to
All right.
delve into it, permission to just ask the question. You will not implant it if you ask the question. That's all.
Yeah. All right. What can we do then going forward? We talked about some of the risk factors, protective factors, some of the signs and symptoms, some of the issues that create an environment that could uh, accelerate thoughts of suicidal ideation, I guess is the right language for that.
Mhm.
What else do we need to know to be mindful of to reduce the risk for our young people,
Mhm.
particularly our Black boys, where we're seeing some of the highest rates?
So that family connectedness and being able to give that sense of community to any person, any youth, all our young Black male, because we know that being a minority, whether you're Black, Hispanic, it comes with a lot of different stressors. And those stressors we sometimes don't talk about, and you hold it internally. And so, having a sense of community, having a network, a village that you can talk with are some of the best things when it comes to preventing these things, because it allows each person an avenue to release that stress, to talk about that stress so they don't feel alone. They don't feel isolated. They don't feel like they have, or they feel like they have a way out. They feel like they have sunshine or light at the end of the tunnel.
Hmm.
So, as a parent, as a loved one, those are the best things we can do. And then just have a low suspicion. If you think of it, if you suspect it, ask. And then you want to consult your healthcare provider. There are quite a few places that you can go to talk to someone. If you suspect someone is suicidal, that's a reason to call 911.
Hmm.
Okay.
Okay.
You don't want to wait,
Okay.
because you may or
So
may not. Mhm.
yeah, no, you may finish your thought because I was going to say a lot of us thinking about calling law enforcement, that creates another layer. And then now I'm in the
Yes.
system, and if someone does uh, make an attempt, now they have to go through a psych evaluation, and some people are. So there's the catch-22, right? I don't want
Yes.
to have
Yes.
my kid in
Yes.
the system, but
Yeah.
then again, I need to save their life. Walk me, encourage our parents through that, because I think that's real for a lot of people, especially
So it's
yeah, especially around our uh, the heightened awareness that we have about interacting with systems that we often don't think are uh, in favor of us. With
so
basically what I'm saying is systemic racism.
yes.
That's
I understand completely.
I
So
just had to name it, right? And so, and how we think we're gonna be, you know what I mean? I don't want to have my kid in the system, so I'm not gonna call.
yeah.
We gotta stop that too.
So
Even if the system isn't always perfect for us.
yeah, so it's very difficult. All right. I can remember just a few weeks ago, there was a young Black man that had an encounter with the police because they called regarding mental health. And
Right.
instead of him getting mental health treatment, I, I think he was killed.
This was
And
in
so,
Rochester, New York. Exactly right.
yeah, so
Yeah.
so these are definitely some very hard decisions to make. And I harp on making sure you contact your healthcare provider, because I truly believe that if you have a good healthcare provider, they can be that gateway, they can be that person that can connect you to resources and the system in a way in which it may benefit you and not harm you.
Hmm.
You get what I'm saying? So
Yeah.
I overall, we need the person to get help, but we need it to be help in a good way, in a helpful way, and not a horrible way as we've seen in the past. So, I mean, there's a suicide prevention hotline that you can call.
Hmm.
That number is 1-800-273-8255. If you're ever looking for just a number to call, if you feel like you know someone that is trying or you are,
800-273-8255.
8255.
800-273-8255. 800-273-8255. We would love for you to, and also there's, locally we've got Contact also, as
Mhm.
Contact Community Services as well, to get mental health support as well.
Yeah.
So
So
800-273-8255. I want to say
yeah,
it. And it's just to remember, calling that hotline doesn't mean that the police are going to show up at your house. It's an opportunity for you to talk and work some things out. And
hmm
we've got to do it for ourselves, for our families, for our community, because the rates are going up. And that's something that we can prevent if we take some
yes.
of the right steps. Dr. Wanda Averhart, anything else we need to know?
No, I think we've covered it all.
All right. Listen, before we go, a little bit about your background. Where'd you go to med school, undergrad, all that stuff?
So I am originally from Chicago, Illinois. I
Uh-huh.
went to undergrad and med school at the University of Illinois,
Uh-huh.
and I did residency at Morehouse in Atlanta.
Uh-huh.
And so I kind of made my way south just to come back up here north.
All
So
right.
I've been here in Syracuse for about 2, 3 years now.
Well, welcome to the Q's, and thank you for your help, Dr. Wanda Averhart. She
Thank you.
is a pediatrician at the Brighton Hill Pediatrics here in Syracuse.
And
Uh,
if you're looking for an excellent pediatrician, I am accepting all patients. So call us. We have a website, Brighton Hill or bhpeds.com.
BHP.com.
BHPEDS.com.
Oh, BHPEDS.com.
.com.
Got
Yes.
it. BH All right, Dr. Wanda Averhart, thank you so much. Inspiration for the Nation. Suicide prevention, 1-800-273-8255. Inspiration for the Nation.